All right, well, good evening and welcome. This is our final segment of Day in the Life, so it's great to have everyone here. My name is Sonal Singh. I'm your third-year medical student at St. George's University, and I'm really excited to be your MSIG Vice President this year. A very warm welcome to all the medical students and the residents joining us today, and a huge thank you to our esteemed panel. Thank you for taking the time to share your experiences with us today. Thank you from all of us. So before we begin, just some quick housekeeping. This webinar will be recorded and posted on the student page of AMSSM website for your future viewing. So definitely please remember to log into your account and access the link when you have time. We will begin today by introducing our speaker panel, and then I'll encourage each of our speakers to please share their background story with the viewers. Next, I'll ask our speakers to provide their insight on a few select questions. And lastly, we'll take questions from the medical students and the residents who are tuning in today. So during this entire webinar, please, if you have any questions that you want our speakers to answer directly, go ahead and send those to us in the chat, and then we'll try to get to as many of them as possible before the end of the webinar. Thank you. All right, so to introduce the AMSSM members on our speaker panel, we'll first begin with Dr. Day. Dr. Day is the head team physician for Purdue University Athletics. She's from Cleveland, Ohio, and graduated from Miami University, summa cum laude, with honors. Dr. Day completed medical school and a PM&R residency at the University of Virginia, while being inducted into the Alpha Omega Alpha Medical Society. Dr. Day did a sports medicine fellowship at the University of Utah and worked at the Cleveland Clinic for 7 years prior to assuming her current role at Purdue. Her research interests include mental health, sleep, iron deficiency in athletes, as well as gender and racial diversity in sports medicine. Thank you for joining us today, and welcome, Dr. Day. Next, we have Dr. De Luigi. He's the chair of the Department of Physical and Medicine and Rehabilitation and the director of sports medicine for the Mayo Clinic, Arizona. Dr. De Luigi is board certified in physical medicine and rehabilitation, sports medicine, brain injury medicine, pain medicine, and musculoskeletal ultrasound. Prior to joining the Mayo Clinic, Dr. De Luigi established the ACGME accredited sports medicine fellowship at MedStar Georgetown University Hospital and the MedStar NRH Interventional Spine Center and the MedStar Sports Medicine in the Washington region. Dr. De Luigi served as the program director of the PM&R residency at Walter Reed Army Medical Center and the National Capital Consortium and the Primary Care Sports Medicine Fellowship at NGUH NRH. During his years of military service, Dr. De Luigi twice served in military deployments in Operation Iraqi Freedom as a battalion surgeon. Dr. De Luigi has extensive involvement with professional sports teams, serving as the head team physician for the Washington Wizards, the medical director and head team physician for the Washington Mystics, and team physician for the Washington Nationals, DC United, and Washington Spirit. Dr. De Luigi also is internationally recognized as a leader in adaptive sports medicine through his extensive experience with disabled athletes. Additionally, he has a prominent role in working with concussion work groups, and he has been highly involved in running medicine. Dr. De Luigi, amongst other accomplishments, also serves as the editor-in-chief for Alternative and Integrative Medicine. Thank you for your service, Dr. De Luigi, and thank you for joining us today. Next, Dr. Hrubes is board certified in physical medicine rehabilitation, as well as sports medicine, and is the director of non-operative sports medicine for Rothman Orthopedics in New York. She currently serves as the medical director for the Radio City Rockettes and as a network physician for the United States Soccer Federation. She specializes in biomechanical optimization, ultrasound-guided procedures, regenerative medicine, and electrodiagnostic medicine. Thank you for joining us today, Dr. Hrubes. Next, we have Dr. Iafrate. Dr. Iafrate is a physiatrist who specializes in sports dance medicine at Columbia University Medical Center. A Canadian citizen, she completed her undergraduate training in Canada at McMaster University, graduating with an Bachelor of Science degree in kinesiology. She later moved to the United States of America to pursue a career in medicine. Dr. Iafrate received her medical degree from Midwestern University, Arizona College of Osteopathic Medicine. She subsequently completed her residency in physical medicine rehabilitation at the Mayo Clinic, followed by a sports medicine fellowship at the University of Iowa. Her primary clinical interests include all types of musculoskeletal injuries, college and professional level sports coverage, dance medicine, diagnostic, and interventional ultrasound-guided procedures, global health and nutrition, and resident teaching. Dr. Iafrate is a peer reviewer for multiple performing arts journals and frequently lectures on musculoskeletal ultrasound. She works with multiple dance schools in New York City and is one of the rotating team physicians for the US ski team. In her spare time, she enjoys traveling the world, dancing, rock climbing, and alpine skiing. Dr. Iafrate is an assistant professor of rehabilitation and regenerative medicine and director of dance medicine at Columbia University Irving Medical Center. She is also the New York Magazine Super Doctors Rising Star in Sports Medicine for the past 3 years. Thank you for joining us today, Dr. Iafrate. Then we have Dr. Stafford. Dr. Stafford is a board-certified physiatrist with a subspecialty certification in primary care sports medicine and is also a registered musculoskeletal sonographer. Currently, he is an assistant professor of orthopedics and rehabilitation medicine at Emory University School of Medicine in Atlanta, Georgia. His current clinical practice is at a level 1 trauma and safety net hospital, where he has the opportunity to provide care for the underserved community of Atlanta, Georgia. He is one of the team physicians for the Morehouse College and several high schools in South Fulton and Clayton counties. He is one of the faculty members for the Emory Primary Care Sports Medicine Fellowship, and his current research includes health disparities in sports medicine, orthobiologics, and interventional ultrasound. Thank you for joining us today, Dr. Stafford. And then last, we have Dr. Zaremski. Dr. Zaremski is a board certified in physical medicine, rehabilitation, and sports medicine. He currently assumes the role of clinical associate professor at the University of Florida, Department of Orthopedics and Rehabilitation. He's the co-medical director of the University of Florida Adolescent and High School Sports Medicine Outreach Program that encompasses 27 high schools and numerous youth sports organizations. Dr. Zaremski also serves as a team physician for 5 high schools in the greater Gainesville area. Dr. Zaremski is also one of the core faculty for the University of Florida Primary Care Sports Medicine Fellowship. He has over 100 poster and abstract and manuscript publications with a focus in sports medicine and upper extremity and throwing related injuries. He published and presented locally, regionally, and nationally and internationally on throwing injuries in overhead athletes involving the shoulder and elbow, including at the International Olympic Committee's World Conference on Prevention of Injuries and Illness in Sport in Monte Carlo in March 2017, on the epidemiology of elbow UCL injuries in adolescent athletes. Dr. Zaremski is also a 2018 AMSSM Traveling Fellow, during which time he visited Norway, Sweden, and Denmark. Dr. Zaremski was awarded the Best Overall Research Award at AMSSM in 2018. Recently, him and his team were awarded a 3-year grant award through Orthopedic Research and Education Foundation Prevention of Musculoskeletal Youth Sports Injuries Grant in honor of Dr. James Andrews. This study will focus on development of a protocol to evaluate baseball pitchers' workloads more accurately. Thank you, Dr. Zaremski, and thank you to all the doctors again for joining us today and speaking for us. We really appreciate you spending your time this evening with us. And now we'll move on. So if you could please share with us your story and the path that you took to get where you are today, we would love to hear it from each of you individually. So if you don't mind, if we could start with Dr. Dave first.
Sure thing. So I think you told us just to talk about our path and how we got to where we were. So I'm from Cleveland, Ohio, was always interested in sports and always pictured myself going into orthopedics. When I got to medical school, I was president of the orthopedics club for a couple of years and rotated with them. And I thought it was great, but I always had fun in their clinic days and that they were dreading. And then they'd go to the OR and I'm like, no, that was okay. Like that was sort of fun, but clinic tomorrow, right? And they're like, oh yeah. And I was like, no, I like that. That's when we get to talk to people. So I was starting to try to figure out, where the best path was for me. And then I found physical medicine and rehabilitation sort of in a roundabout way that I was volunteering for a camp at a camp for kids with disabilities. And one of the attendings was a PM&R attending who was sort of in charge of the medical aspect of the camp. And that was my introduction to PM&R. And fell in love with it and never turned back, and really have enjoyed my path. Out of fellowship, I was at the Cleveland Clinic for 7 years, and covered a Division II school, and a couple high schools, and really learned a lot there. And then a couple years ago, I ended up being the head team physician at Purdue. And it's been great. This year has been crazy. I think we've counted so far, we're up to about 27,000 COVID tests we've done in the athletics department. That's antigen and PCR. So it's been busy, but it's interesting and fun, and I wouldn't trade it for anything.
Thank you, Dr. Day. Dr. De Luigi, would you mind sharing with us your background and how you got to where you are today?
Yes, happy to. Jason De Luigi, originally from Pittsburgh. I had played sports throughout my whole life and knew that when I went into medicine, that's what I wanted to do, sports medicine. Again, going into medical school, really, I thought, was going into orthopedics. That was pretty much all my exposure with sports medicine. During medical school, our dean at Lake Erie College of Osteopathic Medicine was a physiatrist. I'd never really heard of PM&R in my entire life. So she had suggested doing an early rotation. So we had an elective third year, in which I did, and I went to Walter Reed because I had the Army scholarship. And so when I was there, I met, at the time, Major Paul Pasquina. And so he was just had finished fellowship with Fran O'Connor in the military. And so I get there and I'm meeting somebody. I was like, well, I didn't even really know what PM&R was. And then I meet somebody that's doing sports. And so I was like, well, this might be some opportunity, but I still wanted to go into ortho. So the next year I had another rotation there, but before that I had 3 straight audition months for an ortho programs. And so after 3 straight months, the last one was at Walter Reed, and all the people that, like Carly said, that, they didn't say like, well, there's no surgery for you, go see PM&R. And then the next month I saw them, and all the people that we had no answers for, we had tons of answers for. So it was really, so I had already submitted my rank order list, and I had all ortho. And so that was the first year they ever had a pre-select PM&R. And so I switched my #1 rank list to pre-select PM&R. Everything else was ortho. And I went from there. So that's kind of how I got into where I'm at. So during my time in the military, I really enjoyed it. I was doing mostly adaptive sports, working with the Wounded Warriors. We had a very robust adaptive sports program. I ran an amputee clinic. I was the clinic director. So when we did sports clearance for all of our amputees, going and doing some of our, recreational therapies that we had set up with the various aspects. And I knew that I wanted to do more, so was able to get an opportunity to work with one of our sister residencies coming on at Georgetown National Rehab and start a sports medicine fellowship. Work there and got really engaged in all of the DC athletics, as you heard from my bio. So. And then the opportunity for national chair search came up. I'd done a Master of Health Service Administration, wanted to get a little bit more back on the business side of things. And so national chair search, I figured, well, maybe I'll see what it's like. Maybe I'll get an interview and for the future. And they offered me a spot to be chair at Mayo Clinic, Arizona. So I had no plans or intentions of leaving DC, but I thought if I was ever going to go to Mayo Clinic, or leave somewhere, it'd be for a chairman's position and help start sports here, as we really didn't have sports in the Arizona campus. Very well known and robust in Minnesota, but we've been building it here in Arizona.
Great, thank you for sharing, Dr. Luigi. Next, Dr. Hrubes, if you don't mind sharing.
Yeah, so I thought I was alone in thinking I was going into orthopedic surgery before I selected PM&R, but apparently it's a thing. I too thought I was going to do sports medicine, orthopedic surgery. I thought I was really good with my hands, and so I wanted to be surgical. I thought that was the way to do it. But when I was doing my sports medicine fellow or residency, I was doing my rotation in medical school. And I was the same. I was kind of frustrated in surgery because I felt like a lot of the surgeries could have been prevented. And so there was a PM&R guy, Dr. Terry Nicola in UIC at in Chicago who saw a lot of runners, and he was very biomechanical. And I loved how he approached every athlete with, how do you use your body and how can we make it better? And so I was really just enamored with that. And I ended up doing a sports medicine fellowship with him. And because he was so biomechanical, I took that into other sports, more endurance sports, so swimming and cycling, and then performing arts. So when I was doing my fellowship, they decided to keep me there, and I liked it. I like that PM&R is multidisciplinary. I like that we take care of patients as a team. So we were trained by other team members like therapists, and I liked that as a team doc at UIC, which is a Division I team. It's not a Purdue Division I team, but there were still 400 athletes. So we had a team. I got to work with athletic trainers and physical therapists, and I really enjoyed that. And so while I was in Chicago, they made me the fellowship director for a few years, which was fun because I really enjoyed teaching. But I thought it was interesting that it wasn't just the PM&R medical students and residents that they wanted us to train. We would have ER docs come through and family medicine docs come through, peds, and I realized how much musculoskeletal medicine was integral to everything, to everybody's pretty much the way that they live and how they're happy with that. So I really enjoyed that. And then actually I got to be the medical director for Hamilton when they came to Chicago. We were the first sit outside of New York. So that was fun because that's a lot of biomechanics as well. They do 8 shows a week on Broadway and off Broadway in Chicago. So that was another biomechanical mystery that I enjoyed. And then my husband actually got a job offer in New York. So I left Chicago and I left academic medicine. Actually, I'm in private practice now with Rothman Orthopedics. And when I moved to New York, the Rockettes gave me a call and said, hey, we like that you do sports medicine. We like that you understand that performing arts is sports medicine, and we do 40 shows a week. So why don't you come hang out with us? So that's my new team. But I was lucky enough that US Soccer is letting me stay on with them, and I take care of their littler kids. Carly's with the 20-year-olds, so those are the bigger girls. I still look like the mother of the 17-year-old girls. So again, I love that age because it's very biomechanical. So that's what I do, and I love to take care of anybody who has a problem that other people can't figure out. So when they say things like, I don't have pain until the 16th mile of a marathon, or after, I've hit 3 digits in my miles for the week. Why do I only have pain then? I think that's a fun puzzle, and I think that my PM&R training really helped with that.
Great, thank you, Dr. Hrubes. Next, can we have Dr. Iafrate please share your story with us?
Yeah, so I will say I am one of the few, I guess, that knew about PM&R ahead of time and was excited about it. So I'm a Canadian citizen. I went to undergrad in Canada and I was an athlete. I played soccer, I raced downhill slalom skiing because that's what you do in Canada, and I danced competitively. And I sustained 3 knee injuries, which resulted in 3 knee surgeries within 4 years of college. So I spent a lot of time in the PT and with my athletic trainer. And a physiatrist actually treated me, which is why I figured out what PM&R was kind of before medical school. And actually it was my athletic trainer who told me, you're really good with your hands, similar to Dr. Hrubes. Maybe you should think about going to a DO school, because in Canada, they don't have those. They only have MD schools. And so I made a deal with my parents that I would apply to both and I would just go wherever I wanted, because obviously American medical schools are far more expensive than Canadian ones. We have that nice socialized everything. So I ended up getting a scholarship to come down to the States and did medical school in Arizona, realized very quickly how hot it was in Arizona and that I could not tolerate it being Canadian. So rushed myself back north and ended up doing my residency at the Mayo Clinic. I tried to keep an open mind. I loved ortho. I love procedures. I love the OR, but I get super hangry in there. And so I could not have tolerated spine surgery like part of residency at all. I like my procedures like 30 minutes or less. That's how I want it to be. Just like I want my food preparation to take that long too. Yeah, so I went to Mayo Clinic for my residency, absolutely adored it there. I saw Jake Sellen had like hopped on for a second, but so I got to have him and Jay Smith and John Finoff as mentors. and then ended up doing my fellowship at University of Iowa with Moderator Hall. So I really got to kind of hone my ultrasound skills with him further, and got really into ultrasound guided procedures, diagnostic ultrasound, using, 10X in my practice quite a bit. And then Chris Visco, who became sort of a faraway mentor for me after I worked with him for some stuff for AIUM, offered me a job right out of fellowship. So I didn't have to do the big search, which was super nice. And I kind of saw myself moving to New York. I'm not really a small town person. I was born and raised in a small town, but I don't fit there very well. So New York was a good fit for me. I wanted to go into the performing arts medicine side of things, but I loved, doing my fellowship at Iowa, covering D1 sports. College sports is my favorite. I find professional athletes to be a little bit drama queens, but college athletes still have the love of the game. And that's when I had to bow out, right? So I wanted to, similar to Melody, I wanted to get to them before the biomechanics got wrong, because I feel like I could have kept playing soccer for a lot longer if somebody would have done that for me. And so now a lot of my practice is very care for the performing artist. I'm trying to build up the performing arts division of Columbia, because it didn't exist before I got there. This is just really fun to be on this panel, because I interviewed with 3 of these doctors for fellowship. So actually four of them. Oh my gosh, I interviewed with 4 of you for fellowship. So that was fantastic. It's nice to be on this panel. So thank you. And working with the US ski team has been a blast for me, because obviously in New York, we don't have a ton of mountains available. And so I do get to travel. Unfortunately, I was supposed to be in Switzerland last week with the snowboarding team, and Columbia put the kibosh on that thanks to COVID. So unfortunately, no skiing this year, but generally speaking, I am greatly in love with PM&R. I am greatly in love with sports medicine. I love lecturing and teaching at conferences, and the camaraderie in PM&R sports is second to none, in my opinion. I think we're the funnest group for sure. Not that that's the only reason you go into medicine, but by far I think we're the funnest group. And I agree that it's the team effort. It's what pulls you into this. I think a lot of us, that's why we're ex-jocks, a lot of us, and it's because we're attracted to that kind of blended group of, let's figure out how to fix this. Let's figure out how to be the MacGyvers here. So, yeah.
Great. Thank you, Doctor. Dr. Stafford, if you don't mind sharing with us.
Yeah, so I think I'm probably the oddball of the group, because I did not think I was going to go into ortho at any point in time. But growing up, I played a lot of baseball growing up, even competitively, even until when I got to college. And when I got to college, I had a heat-related incident and a fracture dislocation of my right ankle all in the same year. So following that, I decided sports wasn't really for me anymore, and I just didn't have the passion anymore. So going into med school, I was trying to figure out what I was going to do. And I have a mom who was a breast cancer survivor, and I thought, haha, I'm going to be a radiation oncologist. That's exactly what I'm going to be. And one of the reasons, because when she was going through her cancer treatments, the only time that I was not afraid is when she went to go see the radiation oncologist. So I'm doing the cancer fellowship, my first year in med school. I think I'm rocking it. And thank God I had my wife, who was my girlfriend at the time. She said, "What are you doing?" I said, "I'm saving the world. I'm using plant alkaloids in order to save breast cancer cell lines." And she looks at me and she goes, "Every time you walk in this apartment, all you want to do is look at Sports Center or play NCAA football. If you don't find something related to sports medicine, I'm going to kill you." So I decided that she probably was making a whole lot of sense, and I guess she didn't make a lot of sense now. So I started going to figure out the different pathways to get into sports medicine, and really liked the attributes to various physicians. Physiatry's made the most sense to me, the interdisciplinary approach and team approach, as well as really focusing on the quality of life. And so I feel like a lot of times when I'm interacting with my patients, I'm not even asking them what's hurting them. I'm asking them, what do they do and how can I get them back to do it? Whether it's fly fishing, whether it's playing recreational softball. So I do a lot of competitive softball now. So those are questions I end up asking my patients all day long, besides the fact that, how did you hurt your shoulder? But going through that process, I found PM&R, and I knew I wanted to go into sports at that point. So I applied to Emory's, my #1 residency, and I got into there because Kim Mountner was there, who's one of the gurus in ultrasound, Amadeus Mason, who is one of the top guys when it comes to running medicine at the US level. So I really want to get a chance to interact with those guys quite often. And I did a lot during residency. For my fellowship, my love for baseball came back. I ended up going to Birmingham. So I went to Andrew Sports Medicine in Birmingham and did my fellowship. I had a chance to work out with all those various guys who you see on TV. As a matter of fact, Kane was working with Bama last week. So funny story, every time I was at fellowship, there's a room, if you ever go to Birmingham, that has nothing but Alabama stuff. So if you're allergic to Alabama, avoid that room because you'll get nauseous. But now my everyday life now is more helping the underserved. So a lot of individuals that look like me growing up, we didn't have a lot of athletic trainers on our sidelines. And a lot of my friends who played baseball growing up end up having a lot of UCL injuries, but we didn't know that's what it was at the time. All we know is that, hey, this guy's elbow's hurt and he can't go back to playing to where he was before. Or, hey, he keeps having a lot of knee swelling, but we can't figure out why. And so that really kind of drove my passion to work with the population I have now. So a lot of my kids were more Title I schools. And so we typically have one athletic trainer for God knows how many kids, 500 kids at the school. And so to have opportunity to make an impact for those kids, let them know that, hey, there's someone's here for you that's knowledgeable to help you out, but also help them understand that there's other aspects to life outside of sports. And so that's really drove me to where I am today.
Great. Thank you for sharing, Dr. Stafford. And then lastly, Dr. Zaremski, if you don't mind sharing with us.
Sure. So I guess similar to some folks so far. So I was a collegiate baseball player, actually played at Emory, and I didn't have any significant injury until my junior year. Ironically enough, I was actually starting to get looked at by some scouts and sustained a partial tear of my UCL warming up before a game. And at the time I was 9th in the country in hitting. I was hitting like 480, which is pretty good at the Division III level. So that kind of took out the second half of my junior year. And I basically spent more time in the athletic training room at Emory with, I don't think he's still there. Dr. Stafford may have remembered him, Dr. Mountainer would, a guy named Joe Goodson. And I spent more time asking anatomy questions and why did this happen? And, you know, all sort of biomechanical stuff. So, and I was a business major at the time, so I had none of that interested in. So ironically enough, it was the injury that I sustained as a junior in college that kind of got me interested in kind of what I became very interested in. I still pursued baseball as much as I could. After my senior year, I got a look from the Indians, but, you know, never materialized. So I you know, went along the medical path. And by my sophomore year in med school, I knew at Tufts had a pretty good PM&R program. And they also had a pretty good orthopedic program. So I did rotations in each. And ironically enough, I just kind of liked each the best. And then I had to do my neurology rotation. I actually like neurology better than orthopedics and PM&R, but I like the fact that PM&R can combine neurology with orthopedics, so kind of neuromuscular aspect. I like the fact that if I did a really good exam, I had a fairly decent shot at making a diagnosis or having a pretty good differential diagnosis. And that's kind of excited me that I could walk out of the room going, okay, one of these 3 to 5 things is probably happening. Versus I think in other areas, at least for myself, pediatrics, internal medicine, family medicine, I just felt like, well, you probably have, you know, a cold, or, you know, let's give you a Z-Pack and we'll see how you are in 5. And that wasn't really satisfying for me. And as some people on this call know, I am not a very patient person. So I like to find things out right away. Melody, don't laugh. So, so that kind of took me along my path. And really, once I got into residency, I had the opportunity, I was in the same city as Harvard's program, so I got introduced to Joanne Borgstein, who is one of probably the mentors of a lot of people in PM&R and sports and musculoskeletal medicine. And I also happened to be on the same rotation when I was a medical student. Kelly McInnes, who is now the fellowship director at Spalding PM&R Sports Medicine Fellowship, she was a resident. We were on our spine rotation together. So Kelly was a resident, I was a med student, and Dr. Borgstein was attending. So that's kind of how it sort of started for me. And then when I did my away rotation, I got to do it at University of Washington under Brian Kraybeck, who is another well-known PM&R sports medicine person, very established, similar to, you know, Dr. De Luigi as an example. And he helped me, along with Dr. Borgstein, kind of write my first papers on biomechanics and baseball and kind of what it took. And I just started reading more and more stuff. And I had a lot of people ask me why I didn't go into biomechanics. And I said I wanted to see patients, kind of like I think the rest of the panelists said. So all I really want to do, honestly, and I know this isn't a great answer for PM&R residency directors, is kind of musculoskeletal and sports medicine. That's not the best answer to give if you're interviewing for residency, but for fellowship, it's great. So that was really my passion. And then within that, I think as a lot of people know, I have a pretty high interest in biomechanics of throwing. I want to be known as the biomechanics throwing expert non-operatively, because there are not a lot of us. Dr. Stafford and Dr. De Luigi especially can probably attest to that. The field is dominated by either surgeons or some very high-level physical therapists that are well-known for many years. I happen to work with Dr. Andrews and a few others. So that's been my goal, and I got very fortunate with my division chief, Kevin Vincent, who hired me and has really allowed me and some of my colleagues to sort of mentor me and give me the opportunity to pursue some research in that area. And I think I've taken advantage of those opportunities, as my 5-year-old is trying to talk to me right now. So that's kind of my story. I'm at UF now. This is now my 9th year at UF. I see one of our former med students is on the call. I won't call him out right now, but I can see he's on, so it's very gratifying. So hopefully we can answer some questions. And my 5-year-old, who keeps wanting to bug me right here, will let me talk. So thanks.
Thank you, Dr. Zaremski. And thank you to all the doctors. I think I speak for all the medical students and the residents when I say it's really exciting and inspiring to hear about all of your unique backgrounds. So we really appreciate it. All right, we'll move on. And I have some questions. Everyone actually did a fantastic job giving us a lot of insight into some of these questions, but maybe we can tease out some more of the information. So the first question is, why PM&R? What about PM&R makes you, in your opinion, think that this is your best path to a career in sports medicine? And how does a PM&R background give you the unique opportunity to better treat your patients? And anyone can go ahead and answer.
I'll start. So my biggest thing with PM&R, so I really love being on the field. I love being a team physician, as I think a lot of these doctors on here agree. And I always used to say, well, I don't really get the point of being an orthopedic surgeon on the field, because it's not like you can do surgery on the field, right? So who is kind of best equipped to think through some of these injuries and deal with, potentially traumatic brain injuries and spinal cord injuries and musculoskeletal injuries. And really that's physiatry, that's PM&R. And I think that we are really well equipped to deal with the whole gamut of the musculoskeletal system and the human body without saying, well, if I can't get them into the OR and get them in front of into an x-ray right now, I don't know necessarily what's wrong. And I think that the training that a lot of us got in ultrasound, it being something that you can take onto the field with you is huge. And so that's why it made sense for me.
I'll add to that. I think there's two things that, one is the team approach. So, right off the bat, the entire foundation of PM&R is a multidisciplinary team. So particularly when you're learning it on the inpatient side. And even though we're all focused more on the outpatient side, you really get to work with the therapist and the athletic trainer, right? And occupational therapist, speech and language therapist. So when you transition to the field, you're working with the physical therapist and the athletic trainer. So, a lot of times during our rotations, you would go down and watch the patients actually do therapy, right? Which is great. And so it really kind of gives you that opportunity, and then they see you there. And so when it comes down to working with the team, being in the training room and working with that, there's a lot of rehabilitation built into that. And the second part is further explain what Dr. Iafrate had said, was that, one of my goals in PM&R is that I wanted to be able to offer everything I can for my patient except for surgery. So as an osteopathic physician, I could use OMT. Back with the military, we were doing acupuncture, a lot of trigger points. We were doing prolotherapy. That was all pre-birth of all of the regens. So now we do, regenerative medicine, as well as the tenotomies with 10X, I had the luxury of doing the same fellowship as Dr. Day at the University of Utah, where, with Stu Willick, where they taught us interventional spine, and so then I had, a large background with concussion. So when I translated my practice, I would see a mix of all of that. Now that I'm in Mayo, I see concussion only in the concussion clinic, and I have to go to the pain clinic to do my spine intervention. But that was always my one practice. It was, they were like, well, why do you do so many different clinics? I was like, no, I always had one clinic. You just make me put it in little compartments now. So it makes it tough, No, not everybody gets a concussion only on Fridays. So that's why I used to do, 5 days a week of everything. But, I love the full spectrum of providing sports medicine to the patient. I felt that PM&R was the best at getting me ready for that.
One thing that I would add to it is, and this may be me, this may be other folks also, but I was more interested in the why, not the what. Not what is the injury. Okay, you got a UCL tear, or you have patellofemoral syndrome, or you got a stress fracture. Great. Honestly, I can order an MRI. You can order an MRI and diagnose that. The question is why. Was it your biomechanics? Was it you were home for 2 months during a shutdown in March and April, and then you're like, I should run every day? Is it my vitamin D levels in single digits and never checked it before, and now I'm at college for the first time? And I think some of that is very interesting. It's, if you're an inquisitive person and not only do you want to find out the what, but you want to find out the why, I think that's also helpful. Particularly on the inpatient side of rehab, I realize this is, a lot of us are sports medicine physiatrists, but you still have to figure out, okay, so what happened? But why can we improve it? Or why would it be better to improve it? Why might we want to do a different orthosis, as an example? Even though I'm probably the worst person to ask about P&O stuff, why would we want to use a KFO instead of an AFO? Why do you want to use a K2 versus K3 stuff you're going to have to know in your spinal cord rotation or things like that, which can actually very much help you, especially if you get into adaptive sports. And I think Dr. De Luigi is probably the expert on this call. So that was part of me, and that still is part of the case. Yeah, there might be 80% of patients where I'm like, look, you have knee arthritis and your BMI is much higher than it should be, but there's still a good percentage of patients every day going, so you've got this elbow injury, you showed up to baseball practice, if you're in a warm weather clinic like some of us are, and you didn't start a throwing program 2 months ago. Well, this is why the injury is occurring, and this is why you're probably going to see me for the next couple of months, because you're likely going to develop this type of an injury. So that's sort of been my thinking. For better or for worse, I'm usually inquisitive and ask a lot of questions, which at times can be bad, but at times can be very good as well. So that was kind of my thought process of everything. That's still how I try to process things, is why did this occur, not just what is it?
So I'll throw this out there and answer the question in the opposite way you asked it. So you asked why people go into PM&R, but I want to debunk a myth of why people sometimes think they shouldn't go into PM&R and go into sports, because they think that they can't be a team physician. And I think that they think, okay, well, the family med docs, do a lot of family medicine, and they're going to be better poised to be the team physician at a college level. And I'll tell. So again, I'm a Power 5 head team physician, but I'm sort of standing on the shoulders of giants with John Finoff, who's the chief medical officer of the USOPC, Monica Rowe, who's the head team physician for the U.S. women's national soccer team, Ken Mountner, again, who takes care of like every professional team that's in Atlanta. So there's a lot of us doing it. And again, it's when you think about what, at least at my level, at the college level, the amount of medical conditions that 18 to 22-year-olds, deal with, there's not a lot. Like, there's learning to do, but yes, it's a very narrow window. So like, I do know a good amount about type 1 diabetes, to be fair, but like, I don't know a lot about type 2 diabetes, right? But we do have some type 1 athletes, and you have to know that to be a team physician. So you go along the way and you figure out, again, like GI problems, like there are, like we do have a good amount of kids with GI problems, but it's like a very narrow diagnostic window. And then you have experts that you can refer to. But I found myself referring less and less, to be honest, because again, it's really, you can learn a lot about a very small age window at the college level. And I agree with Julie. I mean, college is the best. I just love college kids. I think you don't have to deal with parents as much. There's still some parent phone calls, don't get me wrong, but not as much parents and not a lot of agents as long as they're following the rules appropriately. So it's really you looking at a 19-year-old and being, you know, like I spent an hour on last week on Tuesday, an hour talking to a guy about stopping using drugs because he's an NFL prospect and he smokes pot and he has asthma and his asthma keeps flaring up. And you know, you have to understand, like, I was like, look, I'm not judging you. You just have a lung disease and you are inhaling toxins into your lung. Like, pick another bad habit. That's fine. Not judging you at all. Just don't inhale stuff into the one part of your body that isn't like 99th percentile elite. Okay. And we had a good back and forth. And at the end, he actually said he was going to stop. And I said, no, I bug him once a week and ask him how things are going. But those are the fun parts of the job to me. So long story short is, you know, there's a lot of us who are going into PM&R and being, again, either team physicians or like Melody's doing with the Rockettes, you know, being physicians for a group of people who really rely on you. And it's great. And so I wouldn't let that sway anyone away from PM&R thinking they have to do family med to be a team physician. That's just not the case.
That's amazing. Thank you for that insightful discussion and really great advice all around. We have a question from Aaron Prado. He asks, what are your thoughts on expansion of the fellowship training from 1 to 2 years? I think Dr. Zaremski, you were going to expand on this?
Yeah, I can probably tackle this a little bit. So part of my role outside of UF is I'm the current co-fellowship committee chair with Ken Mountainer for AMSSM. And I'm going to partially answer this question and partially on purpose not answer the question. So currently the Presidential Task Force under Dr. Tracy Ray is exploring, is it worthwhile to expand fellowship training for non-operative / primary care sports medicine fellowship at this time? So as of 2 weeks ago, we are at the stage of Dr. Ray is getting an expert group of approximately 10 physicians, as well as Stephanie Clythermes. She is a PhD, amazing researcher and statistician at University of Wisconsin, and also the director of research at AMSSM, working on a survey that is to go out to fellowship directors in the coming month or two, approximately. But what I can tell you now is there are going to be no decisions made, no changes will be made. This is solely exploratory at this point. I can give you my opinion. What's sort of ironic is being the co-chair of the fellowship committee is I'm not a fellowship director, so I can kind of look at things a little bit more objectively, as well as I've seen a lot of things from the emergency side, family medicine, and PM&R side. Ironically, the only group I really don't interact with much is pediatrics in my role at UF. But I can tell you right now that nothing is going to be done at this time. This is only exploratory. And if something is done, it's going to take a little bit of time. There's about 100 steps that need to be done, but right now it's just exploratory.
Thank you. We have another question from one of our students. How can you go about directing your practice to optimize how many procedures you get to do? And I think Dr. Hrubes, you were going to take this question?
Yeah, I feel pretty passionately about this because I think part of the reason you get a good reputation for doing procedures is when you get a good reputation for not doing procedures. So I love doing procedures and I do a lot of ultrasound guided ones. I also do not ultrasound guided procedures. Not everything has to be done visualized, even though it's fun to do. So I feel like every time I have a conversation with somebody about an injection, I have another conversation about why maybe they shouldn't do an injection or why is regenerative medicine helpful. It's when you've addressed all the causes. It doesn't work if you think it's just going to fix an injury that you're going to just go back to the old biomechanics or the training errors. So, and I find that when you do that, then you have good outcomes. And you have to be excellent at your craft. You have to make sure you do get good training. So where you go and then make sure that you are good before you start doing it on patients. But know all of them. Know not just the PRP and the BMAC and the ASCs, but know how to do prolotherapy and trigger point injections. These are things that are really important in training rooms and for athletes. Same thing like Jason De Luigi said about 10X. That's a big one for some athletes, knowing how to do it well and to keep them knowing how that works in their season or how that works around performances. That's a big deal. It can keep them in a season. It can keep them high performing in a season, which is great. And then they talk to each other and their athletic trainers talk and other team docs talk. And especially if you're in a big city, people are coming into town and there are games that need to be played and they need somebody that can help. So you can be a go-to. But I would say if you want to do procedures, make sure you're very good. Make sure you explain it well. Make sure you explain what not to do well, and make sure you know when not to do them, and be good at explaining that too, because that's just as important a decision. I will step off of my soapbox now.
I was going to say, I completely agree. A lot of times, a lot of my ortho colleagues will send a patient to me for intra-articular hip injections. And so where I am, like I said, I'm at a level 1 trauma center, so I see a lot of hip AVNs or avascular necrosis. And so 9.9 times out of 10, I am talking to them about why I shouldn't be doing this injection today. Or they know that I do a lot of needle tenotomies because a lot of my patients can't afford to do some of the fancy procedures. And at the end of the day, a lot of times we end up talking about biomechanical things that they can do at home because a lot of times they can't afford physical therapy. And so I have to get very creative about how I'm going to treat these patients. And so a lot of times I don't end up doing a lot of the fancier procedures because A, they can't afford to be out for work for a certain amount of time, or B, they can't afford to go through the postoperative rehab because of the restrictions that we put in place. And I think one of the things that my colleagues really appreciate about me is that I just don't look at everyone as just being a procedure. Now, do I have a procedure day when I do a lot of them? Absolutely, and we fill it up. However, a lot of days I'm spent with, hey, how can we potentially fix this before I put my hands on you? And one of my favorite phrases that I say, and I learned from one of my mentors, is, hey, avoid me if you can. I'm a nice guy and everything, but avoid me if you can, because if you see me, something's going to happen. So that's what we end up spending a lot of days. How can we keep you out of office? How can we figure out other ways to be able to do this? And when your colleagues start to see that you're just not a needle jockey or just not envy to do every procedure in the world, then they become a little more trustworthy with your decisions. And then you're starting to optimize your clinic to make sure that you have good outcomes. So a lot of times I'm very, very particular about which patients I'm choosing, because in the day, I want to make sure they do well. Because this is just not a one-time thing. This is a forever thing. And so I'll get off my soapbox too now.
Thank you. We have another question from Josh Romero. He's a current PM&R resident at Mayo. He asks, how common will it be to offer high-level ultrasound procedures like carpal tunnel release and other things?
I can start out. The short answer is it depends where you practice. Aside from when you are doing your training, whether in med school, residency, fellowship, I can tell you that, and all of us on this panel can say this to one perspective or another, and probably Dr. De Luigi has the most experience at this, is it depends on the political atmosphere. It depends who is the chairperson of your department. It depends who is in charge of certain procedures, such as orthopedics, anesthesia, neurosurgery, etc. Depends on the historical nature of your department or university or private practice. If you're in a private setting versus if you're in an academic setting, I'll give you an example of my institution. Right now, 10X is not done because the cost of the kit is more than the reimbursement. And at a state institution, figure it out. And this is pre-COVID, by the way. This is not just in the last year. So I would answer that when the time comes, because if everyone on here is a medical student or even a younger resident, you've got a couple years. You want to make sure that and actually, I'm going to back up. I got a great line once. Part of it's from Dr. De Luigi, and part of it was from Dr. Mautner, is you want to be able to go to a job where maybe you can get 70 or 80% of what you want to do, but your chair, division chief, will allow you to grow into the last 20 or 30%. You will not get to do everything as a first-year attending. It's not going to happen. Jim Andrews didn't get to do that 40 plus years ago. But you want to have the opportunity and the ability to do that, to expand it. Dr. Iafrate's former fellowship director, Dr. Hall did not become this amazing ultrasound guru his first day at Iowa. He had to expand, show the research, get his grant money, et cetera, and you push for it a little bit each year, and you have to show results. So in part, that's my little bit of a soapbox of when you're ready to look for jobs, you have to see what the chairperson and the institution is going to allow you to do. And it's going to be different at every place. It may be different down the road when there's multiple institutions. So I'll let other folks chime in, but that's just one thing I wanted to give a piece of advice on.
Yeah, I'm going to chime in a little bit because Josh, I came from Mayo, so it's a bubble, right? You live in a bubble there and everything's like, oh, this all works perfectly. And nobody pays for anything and it's all beautiful. And that's not real life. I will tell you that I had a big wake up call when I came to Columbia. And I think I'm the newest attending on the panel. And so I will say when I first interviewed and I said, this is all the stuff I want to do. And they kind of chuckled at me and they're like, okay, maybe. Dr. Zaremski said. So basically it was about, what's the most important things to you that you want your practice to involve. And for me, it was some of the higher level procedures because I really enjoy doing those. And there was a niche for it. So Columbia, I'm going to use 10X as an example. At Columbia, nobody was doing 10X. And it's because they couldn't figure out how to get it covered. Now, if you do it in an acute surgical center, it will be covered. And so the cost of the kit no longer is, a big issue anymore. But if patients want to do it in the clinic, which is how I learned how to do it with Dr. Hall at Iowa, then they have to pay out of pocket. But Hall somehow figured out how to turn Iowa's sports center into an ASC. I don't know how, it just worked out well for them. But in New York, that didn't work. So I'm actually doing the procedures at in basically an OR that they give me. So I can only do them on certain days. I have like 10X days and that's it. I can't in the middle of the week or anything like that. And so, it takes a lot of pre-planning. It's almost like I have an operative schedule as well. And that would be the same with doing like carpal tunnel releases or anything like that, some of the bigger procedures. I agree with the turf statement. A lot of it, there's a lot of potential turf wars and you could make people very angry. So I think when you first start out, you need to prove that your hands are good and prove that you know what you're doing. And then maybe show them and kind of reason with whoever you might be, quote unquote, stealing the procedure from, that I'm not here to try to take over your practice. I'm here to be an adjunct to it. So, a carpal tunnel release on a pregnant woman's a pretty good option if you could do it percutaneously as opposed to bringing her into the OR, or somebody who can't go under general anesthesia, for example. And so finding those like little areas where the practice can blend is a really good idea. And one way to do that is to, offer to try to think of case studies that you could do together or research that you could do together so they can see you in action. And that's been what's been successful for me. But it took a while. Like I'm 3 years into practice now and my 10X practice really just built up in the last year.
Thank you. We'll take one more question. We'll try to get another one if we can. But Costa Nikolozakis, sorry if I butchered that. He asks, can you elaborate on how different your team physician days of the week look compared to your more standard outpatient days? And thank you, Dr. Day. I know you already chimed in on that, but if anyone else would like to answer.
Go ahead, Jason.
Me? Okay. Well, so the way my practice works, which I think most of us, except for probably Dr. Day, works, is most of us have a certain amount of clinic days. I'm 80-20, which is so 4 days clinic, 1 day administrative. That's a pretty straightforward clinic schedule, depending on if your department or university will give you some administrative time. And my clinic schedule, I start early because I never sleep. So I start like at 7 or 7:20 in the morning and I go till 4 o'clock. And I just see patients all day, every day, except for Wednesdays. So I can tell you that when you're covering events, your team physician days are called, you head over to the athletic training facility or you go cover your game after clinic or on the weekends. On the rare instance that maybe your high school made it to the state championship and you have to travel. And I know some states that wasn't happening this fall, Florida, whatever your opinions are, we never closed. You might miss a Friday or something to travel, but otherwise it's all on you. You pay for your own gas for the most part where we are. So that's how it is. And I actually give a talk to the AMSM fellows each year basically of what sports medicine actually is. And a lot of it's volunteer work. You're not going to be in Sports Center. If you are, that's probably not a good thing. You're not going to be on Fox Sports. You're not going to be in the newspaper. You're doing it for the love of the game, which, you know, obviously is a little cheesy, but it pretty much is true. I'll let Dr. De Luigi go, so he was going to chime in also.
Yeah, so, you know, training room days versus, you know, clinic days. So it depends. So I've had many different variations. You know, currently I'm the team physician with the Phoenix Rising soccer team. So I have training room. When I see the patients in the training room, we don't charge them because it's part of our contract. If they were to come to the clinic and they needed something, then they would be charged through their insurance. When I was with the Wizards, for the first 2 years, it was similar to that, but then they wanted me to do more. So they subsidized 2/3 of my salary, and I was going in and doing training room every morning, every day of the week, as long when they wanted me to come. And then I was traveling with all road trips, which were 3 games or longer, you know, so that was a lot different, which is why they were subsidizing so much more. You know, so I was missing lots of days of clinic. And then when I was done with the, you know, training room at noon, you know, I'd run over to the clinic, and if somebody got hurt in practice at noon, they want me to run back over. But usually, because I was in clinic, I'd send them over to me. So that was, a much more varied portion of it. So.
I can chime in from a private practice perspective. So I have a contract with the Rockettes where they pay me a certain amount of money. We decide about how, you know, what I have to do in season. I only have training room in season, but it can be, I can have to run it over to Radio City a couple times a week. So it's nice that my office isn't far from there. But also because I'm in an orthopedic clinic, I know that if they have any injuries where we need to get x-rays or I'm worried about something, that they know that they'll get amazing care from better than the ER if they just come directly to us. So that's a kind of a value added thing. Anything that I see in training room is covered by my contract, and anything I see in the office is covered by their insurance or work comp if they're injured on the job. So, but part of the problem of being a team doc is that you have training room and then you have call. And I'm sure all of these team docs can say that they don't get to turn their phones off and you don't get to put it on silent because everybody has to be able to contact you at any time. So that goes for soccer, that goes for Broadway, that goes for the Rockettes. So when you don't know when they're going to get injured, and it's usually after my bedtime. So unlike Jason, I sleep and I sleep early. So my phone is on ring and it has to ring loudly to wake me and my husband and my dog up.
Thank you again to all the students and the residents for those great questions. I'm very sorry, I know there's some questions that we didn't get to, but if it's all right with the panelists, I know some of you already dropped your email in the chat, but if any of the rest of you would like, if you go ahead and send us your email, I'm sure the students who didn't get to ask their questions can send you those questions, hopefully through email for you to answer. But thank you again to all the AMSSM members for serving on our speaker panel. Sadly, we're at the end of our webinar. I know if it was left to us, we'd love to keep you here all evening to ask you questions. Thank you for your time with us today. It's truly been invaluable and we all very much appreciate it. The residents and students, again, thank you for joining this very impactful webinar. And to those viewing in the future, I hope you enjoy everything we discussed. So last thing is your MSIG is currently planning more webinars for the year ahead. So please do look forward to tuning in. We also love to hear suggestions for new webinar topics. So please enter any ideas you have in the chat, or you can email us your ideas. I'll go ahead and drop our MSIG email in the chat now. Again, thank you to all the speakers and all the attendees for spending your evening with us. Everyone, please stay safe and motivated. Thank you and good night.
Thank you.
Thank you.